instructive, highly educational.
Thank you. So we'll move on to the next talk. Cardiomyopathy and moderatized stenosis should be treated, Dr. Nagendra.
Great. Just one point I forgot to make about amyloid. You would always screen for amyloid for blood flow.
Okay, thank you Dr. Sai and NTA team for providing this opportunity. And a couple of speakers are not available and grabbing 2 minutes extra time, and I got so much of the same. So I don't have any conflicts regarding this particular presentation. I'm going to discuss 3 scenarios. A couple of scenarios have already been discussed by the panelists and chairpersons here. Scenario number 1 is an elderly male who came here for dyspnea on exertion evaluation and clearly has got a severe aortic stenosis kind of picture, reduced exertion, calcified valve, possibly a type 1B bicuspid anatomy. However, the mean gradient here is only 18. Aortic valve area by continuity was less than 1. And of course, we proceeded with the lobotomide Seseko. Lobotomide Seseko showed increase in P gradient and aortic valve mean gradient more than 40, and aortic valve area was less than 1.2. So I would request the audience to use their phone, scan it. Unfortunately, the Slido is not working here. Okay. Anyway, so of course this is very clear. Low flow, low grade aortic stenosis went up to a higher gradient, and then we have to send the patient for either surgery or TAP. That's a different story. Another patient, elderly male, again a calcified aortic valve, low flow, low grade aortic stenosis, low stroke volume index, low flow rate, baseline echo, mean gradient of 17, aortic valve area less than 1 by continuity equation, low dose lobotomide, peak dose lobotomide. Valve area has increased significantly, you can appreciate the here, and the mean gradient remains the same. He is under follow-up on medical therapy. Unfortunately, the Slido is not working because of, I don't know the reason exactly. Anyway, so now we have got evidence from TAVR and NODE telling that in patients with moderate aortic stenosis with LV dysfunction, we may increase their quality of life, however there is no change in outcome. This is a small study. The same question is answered by Progress trial. I am aware that the study will be presented in TCT 2026. Our concept about evaluation of aortic stenosis may have a paradigm shift once Progress is going to be presented or published. They have finished recruiting the patient. Patients are getting followed up now. This patient is doing well almost 2 years now. So clinical scenario number 3, 69-year-old female, body surface area 1.4, she looks like 85 though. Dyspnea on exertion class 2, angina on exertion class 2, normal difunction, diabetic, low euro scores, moderate severe AS, valve area 1, peak gradient 55, mean 34, was done in November 2025. Persistent symptoms, we labeled it as moderate to severe AS and then send her for, okay, let's follow her up. Couple of OP visit, couple of 3 to 4 times OP visit because of persistent symptoms, re-evaluated again. LVH is there, I mean the valve area is 0.1, 0.8, Vmax 3.9, mean gradient is still low, DI is 0.28. This is the echo of this particular patient. It's a tricuspid valve, kind of mild moderate calcium. Looks like reasonable, kind of reasonable opening in 2D short axis. GLS is normal. Okay, since he had a kind of angina, we thought, okay, are we missing a CAD? It's a left dominant system. Coronaries are clean. We did as per the current EAC, we proceeded with evaluation of calcium score. The annulus is small annulus. Sinus is good, the heights are good, calcium score is 524. So, to summarize, here we have a patient, 16-year-old female, aortic, low flow, low gradient aortic stenosis, possibly a paradoxical variant versus moderate AS. As per the EAC 2025 getting evaluated, having an aortic valve calcium score of 524. So groins are fine, good to go. What next? Okay, slides are not working. Now I would like to stop here and proceed with the discussion with the analyst. How do you proceed further? I mean, yeah. Oh, I can't see the slide. You guys can see it. Maybe you can scan it and vote it.
Maybe one of the options, a fourth option would just be continue surveillance.
Continue surveillance. Okay, that'd be great. Maybe you have to show the Slido.
Put the slider for people to scan and vote. Yeah.
The response is quite poor, I believe. Okay. The ACC is currently outdated. It's 2020. Maybe next year they may come up with fresh guidelines. EAC is the one that is quite new, 2025. So okay, the response is quite variable. However, most of the response favors, okay, it's equivalent. I would do DAC, I would do integrated approach, I would do TAVI, and okay, I would do DAC is the most higher option. Okay, I would, this is the situation what we have. The points favoring moderate aortic stenosis are quite high as compared to points favoring paradoxical severe AS. Presence of normal GLS having a TI more than 0.25, mean gradient 34, aortic valve calcium in the CT scan 524, favors moderate AS, while stroke volume index 34 less than 34 and aortic valve echo continuity less than 1 favors paradoxical AS. So as per the EAC 2025, we should select integrated approach. What it says is aortic valve calcium score. If your aortic valve calcium score is not fitting the criteria, the original criteria was from the 2000 studies where it showed that more than 3000 is very likely, more than 2000 is likely, and less than 1600 is unlikely for males. For females, more than 2000 is very likely, more than 1200 is likely, and less than 800 is unlikely for severe AS. So our patient is a female patient, her calcium is 524. She falls into this integrated assessment. That's the right answer for this particular approach. What does integrated approach means? First point, going back to basics, assessing the symptom of the patient. Do I have any other reasons for the patient? No. As the evaluation concerned, almost everything is done. We don't have any other evaluation. No other reason to hold. Is there any other echocardiographic evidence of LVH? Yes, it's there. The LVH thickness is 14 millimeter on the posterior side and IVS side is 13 millimeter. Other most important thing is the 3D valve area from the CT scan. This is often missed. So the 3D valve area for this particular patient is 0.85 centimeter square. The data of recently published Jaha paper says that we don't need a less than 1 centimeter square aortic valve area by CT scan. An aortic valve area by CT scan of less than 1.2 is good enough to correlate with echocardiographic aortic valve area. It's a very good sensitive marker. However, the specificity for the same is poor. So now we have aortic valve CT scan score, which is 0.8. Again, I was not convinced. I mean, first point as a physician, primum non nasal is the key here. Am I still dealing with the moderate AS? Should I do it or not? Is the question that was coming to my mind. So I took that. Again, I would appreciate the option. So I didn't get convinced. I would like to know the response from panelists, the audience. How many of you might have proceeded with TAVI? How many of you would have assessed, would have evaluated further? Okay. Okay, so most of you would have proceeded with TAVI. Okay. Okay, so I wanted some more evidence. So I got the NT-proBNP, which is also a part of integrated approach. Since I was told this should be an educational case, I thought how I approach this case. Most of the thing what I am discussing is very well aware by most of you guys, but still I would like to emphasize. The NT-proBNP for this particular patient was 250. The lower limit for this particular age group is less than 125. So now still it is balanced. Now the patient, since I was going very slow with evaluation, patient got multiple opinions, which most of you practicing India come to know they will go to multiple opinions. Luckily suggested, the operator suggested that the patient is getting evaluated properly, and she came back to me. I was unaware of the same till that point of time. Having said, now I was actually considering about, okay, it's equal between moderate and paradoxical aortic stenosis. The 2022 ESC, I don't know the reason why the 2025 ESC took out the dobutamine evaluation. I would like to know from experts like Chandrasekhar sir, why they took out, I really don't know. It's a wonderful investigation even for paradoxical aortic stenosis. It has got a very good positive predictive value, but a very poor sensitivity. That by saying that you may miss a severe aortic stenosis by doing dobutamine alone, but if it is positive, it is positive. That's it. So that might be the reason why I think they might have taken it out from the ESC 2025 guidelines. So possible reasons in this particular patient how dobutamine can affect this in a different way, I have enlisted them. So dobutamine low dose was initiated for this particular patient. I was not still convinced, should I keep her on medical therapy or should I proceed with TAVR? So with initial gradients, her gradient increased to 75-42 with low dose of dobutamine itself, and she started having significant symptoms in the form of breathing problem. So now I got convinced, okay, I am definitely dealing with the paradoxical severe AS. Till the point of time the patient has not told that, she has met one senior cardiologist who is an excellent echocardiographer also, who runs her own center in Chennai. And then I called him to confirm the findings, and then I proceeded, okay, this patient needs a TAVR for sure. The procedure is not a routine thing. We proceeded with this self-expanding Hydra platform was performed. That was not the case. To conclude, integrated approach in paradoxical aortic stenosis with normal aortic wall calcium. This includes assessing the symptoms, going with ECG, any evidence, looking for evidence of LVH, which cannot be explained by other diseases like amyloid. Looking for advanced echo parameters like GLS. Look for biochemical parameters like biomarkers like NT-proBNP. Integrated CT assessment, measuring this aortic wall area by means of CT scan. Understanding the sensitivity and poor specificity of the same is very essential. I still use dobutamine in my practice if I am not convinced about the severity. And till the time moderate aortic stenosis with LV dysfunction should be treated medically until unless we change our therapeutic modality after progress trial. Thank you.
Any questions, comments? Ajay sir?
Only one thing, I might have done an exercise test for her much earlier down the line. Because for me, that is an excellent stressor and it uncovers symptoms. And it also gives you the opportunity to assess the hemodynamics in response to exercise. The patient is coming to you with dyspnea on exertion. And second thing, when we did the angiogram, I might have
excellent. Yeah.
These are the two things additional which I'm doing.
Yeah, I was regretting not doing a cath at that point of time. I didn't consider exercise because she was symptomatic. I consider exercise only for asymptomatic patients, but her hemodynamics definitely would have been much better at that point of time.
Exercise tells you two things. Number one, the effort tolerance and symptoms.
Yeah.
And exercise echocardiography, I think, is an excellent tool to detect what exactly.
I agree with you, sir. Maybe a simple manual like leg raising might have helped. I missed it. That was the lacuna in managing this particular patient. I'm still learning.
Can I ask how did your patient feel at follow-up post-intervention?
It was done last week.
Oh, okay.
She went home.
1 week follow-up, she's doing well. No, this is fantastic presentation. I think as usual, yours is like step by step and how to assess it. It's exceptionally good, especially for people who are beginners and need to know. Same principle applies, I suppose, for the asymptomatic severe aortic stenosis as well. Yeah.
Yeah.
It's like kind of variation.
Again, after early TAVR, I mean, I give the choice to the patient these days. 44% of the patient either they get the procedure done or they have hard endpoints. It's up to you to take the point. We have done a meta-analysis before early TAVR that says that there's no added benefit of getting a TAVR done in asymptomatic patients by means of death or MI or stroke. However, heart failure hospitalization significantly reduced. So in my practice, I give the information to them. Most of them disagree. A few of them agree. Then I proceed for TAVR.
That is another group in which, I'm sorry.
Yeah, please.
Yeah. I said that's another group in whom the exercise testing is of great value.
Yeah.
Patients who have got excellent effort tolerance, whose anti-BNP is not high, just because the echo shows something doesn't mean that we have to rush and do a TAVR. And even in the endpoints are very important. If you're going to offer somebody a free TAVR in case they develop symptoms during the follow-up of the trial, I guarantee you 90% of them are going to develop symptoms that they have to try for other reasons.
Yep.
Yeah, I think we can dissect that the early TAVR data more to make some thoughtful decisions and application. And of course, early TAVR, if you're going to apply the data, is not to an elderly, comorbid, frail population. That was not studied. So
The
it's
most important point, what they did was doing a treatment test for all the patients. That is the key point.
Yeah.
That's fantastic. I think you are here, so we might have just another 4 or 5 minute discussion on the topic which was not presented. The other one was the coronary artery disease, aortic stenosis. I'll probably start with you. Your approach, CAD with AS.
What is being told by evidence is I have been badly fired last month. I used to do what I have been taught. We used to in Sinai we used to do a coronary valvuloplasty, fix the coronaries, stage the TAVR later. Unfortunately, in India we could not do stage procedure because of financial constraints. So in my practice I do PAV, PCI and TAVR. But following evidence, I started doing TAVR alone. Most of the time, many times it went well. But the last month I had a bad situation where the densely calcified LAD disease, this is extending into ostium. Balloon expandable valve was placed. Patient had a refractory EF, shocked 5 times, intubated. Then we have to do a rotablation IV PC to LAD. He had a RB, right button branch LA fascicular block, LA anterior fascicular block with full PR. He developed complete heart block after the valve. I thought of going for a pacemaker upfront. Now with PCI, I thought, okay, let's postpone the pacemaker. Next day we get a pacemaker. So now this patient also had angina too. He had dyspnea and angina. So even the reason for TAVI says no need to fix it. We can do TAVI first and do PCI later. But I think we need to give importance to the symptoms of the particular patient. My patient did not tolerate a couple of rapid pacing that led to ventricular fibrillation. Maybe that was very critical LAD, maybe 95% LAD disease. Next time if I get a similar patient, I would hesitate to do a TAVI first. I should have done a balloon aortic valvuloplasty, go back to my original school of thoughts, fix the LAD, come back and do TAVI again. It's open for discussion.
So, sir, non-left main, non-LAD, non-ACS, your approach?
Yeah, I think that narrows it down much more. And if the coronary artery, if the the ischemic burden is not large, I would definitely go and do the TAVR first because I think that's what is causing the problem. The issue is that patients often haven't read the books and they come with different combinations. And even if you review the evidence, the bottom line of everything is if you can figure out which one is brought the patient to you, that should be fixed first. If you can figure out that this is severe AS, but the gradient is not too high and he's got a proximal LAD that is severely ischemic or a distal left main which is severely ischemic, probably that needs to be fixed first. And I'm aware of the data in which they have done both together, and they've done PCI first, and they've done the TAVR first and everything. I think this is an hour's discussion. It has to be individualized. I do feel that what is more important for the patient or what has brought the patient to you has to be handled first. Having said that, CTOs, distal disease, I think they can be forgotten about in case one is just doing a TAVR. I don't endorse the view that you needed to do an angiogram at all. In patients who have got LV dysfunction, who are symptomatic with angina, we will always do an angiogram. In patients who have just got heart failure, even then, once LV dysfunction has occurred, we will always do an angiogram. First, you need to know whether he's got pulmonary artery disease as well, and then make a decision accordingly. We will never do it together, and we have twice taken the option of doing the TAVR and sending the patient for an op-cap when we feel he's got a very, very bad disease, which is not likely to give a good long-term result with the PCI.
Ganesh?
Can you hear me? So I have a very simple rule of what I do. So if it's not left main, I think left main is treated before. But if it's dominant LV, dominant circ, or dominant right, the question you need to ask yourself is what will the patient go through if there's an episode of hypotension? And I think in your patient it was a very nice case where the rapid pacing during the balloon expandable valve triggered the ventricular arrhythmia that was resistant to come out again. So you need to think about what will the patient's LV do and rhythm do during the hypotension. It could be the severe AR you caused during deployment or the rapid pacing you need to do during deployment. Either of these, if it's not tolerated very well, you start a cycle of spiraling downwards, which will be very difficult to recover while the patient has severe aortic stenosis. So, the rule that I've used like 15 years, if it's proximal AD, proximal right, dominant circ extended, regardless of the symptom or not. Anything else, I'll leave it. If they're extremely, then I individualize to the patient. If they're extremely elderly and they have no symptoms, I've now regretted not doing the PCI first. Because then you have an elderly patient with dual antiplatelet therapy and you're trying to access the groins and they're not normally good. The reverse I've noticed when somebody with severe LV, severe chronic disease and severe aortic stenosis. I've had lots of elderly patients, by fixing the coronary arteries, they become completely asymptomatic for at least 2 to 3 years. Now to a point now where they become elderly, very elderly, and now symptomatic. At that point you don't know whether it's the valve, their frailty, or their age. And in those patients, by leaving them alone and telling them not, and so it has to be individualized, but otherwise, the dominant vessels, I think you need to treat before them.
And when you do the PCI and TAVI, so you do the PCI first, and what time period do you do?
Yeah, so I think in my hand I can count the ones who have done a left main and a TAVI at the same sitting. But my rule of thumb is 1 month.
Yeah.
I do TAVI, I do the PCI, and then I let them wait for 4 weeks. Gives you the advantage. We had to stop that. You can reasonably safely do it now.
From the final comments question.
Yeah, I agree with that. I mean, we don't routinely cath our patients. It is very individualised, though. The question is, what is the goal of treatment? And in our largely elderly population, if they don't have angina, don't cath them. If on the CT I see that there is suggestion of left main, significant prox LAD, I'll cath them, because to Ganesh's point, there are implications for my peri-procedural TAVI issues. That's why.
So you cath them before the TAVI procedure or during the time?
No, before. Because I want to plan it. I want to know. I want to plan.
Crucial.
Yeah.
Yeah.
I agree with Ganesh and all of you. For the critical lesions, they often sometimes need to be treated. I think the key, we're the second biggest recruiter for Notion 3, and there's a nice FFR sub-study just about to be published, which is quite interesting. I think the key from Notion 3 is getting used to the fact that we shouldn't over-treat the patients, and they are elderly and they do bleed and they do have complications. So that's the take-home message for me. We don't do an angio pre-TAVI, we just do a CT to look for the proximal disease. We don't get a routine angio.
Absolutely, I think most of us probably adapt the same thing. So the CT shows there is no significant proximal, don't do it. If there are symptoms, as you said, do it, but do it in a separate procedure, not during the index procedure. Any final comments? Otherwise, we'll close the session. Yeah. Fantastic. Thanks for the speakers and excellent boopathy as well as Chandrasekhar sir. Thank you.